benign breast disorders. Let us talk about benign breast disorders. In benign breast disorders, we have a non-proliferative conditions and we have proliferative conditions. We have non-proliferative conditions and we have proliferative conditions. Non-proliferative conditions include breast cyst, duct ectasia, mild hyperplasia, and fibroadenoma. Proliferative breast disorders include moderate hyperplasia, florid hyperplasia, atypical ductal hyperplasia, atypical lobular hyperplasia, sclerosing adenosis, intraductal papilloma. These are the various non-proliferative and proliferative breast disorders. Now, importance of knowing these conditions in this way, that is non-proliferative and proliferative, is this: that none of these conditions have risk of malignancy in future. So all these conditions, these non-proliferative conditions, all these non-proliferative conditions are purely benign and they have no risk of malignancy in future. However, in these proliferative conditions, most of them have a risk of malignancy except these two, except sclerosing adenosis and intraductal papilloma. Except for sclerosing adenosis and intraductal papilloma, rest all are pre-malignant conditions. Except for sclerosing adenosis or intraductal papilloma, rest all are having a risk of malignancy, that is, they are pre-malignant conditions. Now, there are a few conditions which we should know about in these benign conditions, and one of them is duct ectasia. Now, can you tell me what is duct ectasia? What is ectasia? Ectasia is dilatation. Ectasia means dilatation. So, what is dilated here? Duct. What is dilated here? Duct. So, in this condition, this is a condition where there is usually dilatation of multiple ducts are there. In this condition, usually there is a dilatation of multiple ducts are there. Okay. Now, how does this patient present? First of all, most common age of presentation of these patients. If that you think is young, more than 50 years. So they'll be more than happy if you tell them that they are young, but it is more than 50. Most common age of presentation is more than 50 years. And what is the most common presentation? Yes, it has to be nipple discharge, because if you say discharge, it can be a nasal discharge also. So it is a nipple discharge. अरे यार कहानी खत्म करने से अभी तो निपल डिस्चार्ज शुरू हुआ है, अब देखेंगे कौन कौन सा आ रहा है. In this nipple discharge, there are various types of discharges from nipple. There can be serous discharge. There can be green colored or grummus discharge. There can be a toothpaste-like discharge. There can be a blood stain discharge also. Grummus. Right? And out of these various types of discharges from nipple, the most common discharge from nipple in duct ectasia is serous. But you should be very careful that once there is a toothpaste-like discharge or grummus or green color discharge close to you, one should think of duct ectasia. The chances of duct ectasia are very high if it's a green color or a toothpaste-like discharge. Huh? Tooth के बाद पेस्ट दिखा, पेस्ट के बाद ब्लड दिखा. ठीक है. So if you find a green color discharge or a toothpaste-like discharge, you should always think about a duct ectasia. Now, a patient who has a discharge from the nipple coming out, a patient who has a discharge from the nipple coming out can also develop inflammation of the nipple. And but if there is an inflammation of, or if there is inflammation around the nipple happens, what will that be called? Periductal mastitis. That will be called periductal mastitis. It is associated with any color discharge. If it is duct ectasia, it is associated with that. Okay. Now, which individual has more risk of developing a periductal mastitis? That is very important. Huh? It is those who are smoker. Smoking. If the female is a smoker, there are very high chances of developing periductal mastitis. If the female is diabetic or immunocompromised also, then also there can be a risk of periductal mastitis. And once there is a periductal mastitis, you can appreciate any inflammation once settles, it settles with fibrosis. So after periductal mastitis, there will be contracture of the lactiferous duct, and because of that contraction of the lactiferous duct, there can be a slit like retraction of nipple. So that means in a patient who has a duct ectasia, there can be a slit-like retraction of the nipple possible. In a patient with duct ectasia, there can be a chances of a slit-like retraction subject to condition if that female has developed a periductal mastitis. Confirmation of diagnosis. Confirmation of diagnosis of duct ectasia is by galactogram which is also called ductography. Confirmation of diagnosis of ductectasia is by galactogram or ductography, and the treatment of choice for ductectasia depends on, in a given question, if you are told it's a ductectasia involving single duct, or if you are told it's a ductectasia involving multiple duct. If it is specifically told to you in a given question that it's a ductectasia involving single duct, your answer should be then microdocectomy. Your answer then should be microdocectomy. Removal of that single duct which has a problem is called microdocectomy. Multiple duct, if the discharge is coming, your answer should be radical duct excision, or which is also called cone excision, or which is also called Hadfield's operation. Very good. Cone excision, Hadfield's operation, or radical duct excision. And if by any chance, imagine you are not told the number of ducts involved and you are asked what is the treatment of choice of ductectasia, what will that be? Why? Usually it is involving, because usually it is involving multiple ducts. So your answer should be radical duct excision or cone excision or Hadfield's operation. Good. Then comes fibroadenoma. You should be able to make out, because you are now going to get a clinical question. So you should be able to make out a difference between a fibroadenoma and there is a similar condition which is having a similar kind of presentation in clinical practice, and that is phyllodes tumor. So how to differentiate fibroadenoma from phyllodes tumor, we should be able to decide. First of all, fibroadenoma, the most common age of presentation of fibroadenoma is less than 30 years of age. Listen to this very carefully. The most common cause of breast lump in less than 30-year-old female is fibroadenoma. Remember, the most common cause of lump in breast in less than 30-year-old female is fibroadenoma. And can anyone tell me that what is the most common cause of breast lump in more than 30-year-old female then? Very good. It is carcinoma breast. Most common cause of breast lump in more than 30-year-old female is carcinoma breast. But it doesn't mean, see, always is always wrong, never is never right. So it is most common. It doesn't mean all females, if they develop a lump, it is always a carcinoma. But it is just that chances of having a carcinoma will be very high if a female develops a lump after 30 years of age. Now, in case of phyllodes tumor, the age of presentation can be young female or can be a female of more than 50 years. So that means it is quite possible that in a given question, you are provided with a profile of a phyllodes tumor because a phyllodes tumor presents less than 30 years of age also. So that means age, if is more than 50 years, then obviously you will not think of a phyllodes tumor you will not think of a fibroadenoma in a given situation. But if age is less than 30 years told to you, with that age, we will not be able to figure out whether it's a phyllodes tumor or a, समझ आ रहा है मैं क्या बोल रहा हूँ, right? So age, if more than 50 years is there, then we have a clue that probably it is a phyllodes tumor. But if age is less than 30 years of age, we will not be able to figure out until unless we have findings which are suggestive of a phalloid tumor or a fibroadenoma told to us. So that means age less than 30 years may not be a clue in a given question. समझ आ रहा है मैंने क्या बोला? Now, the most common presentation here in fibroadenoma is lump breast. The most common presentation of a phalloid tumor is also lump breast. So then, how will we differentiate if both have a lump breast? The basic point in lump breast is size. Size. What is the most? Size. Yes, size. It is the size which matters here. Right? Size matters, so it matters here also. Right? And in this size, if you are told it's a big size lump, one should start thinking towards phalloid tumor, right? Then, on examination in fibroadenoma, you will get a firm lump, firm in consistency lump, which is having smooth surface, which has a smooth surface, and well-defined margins, and it is highly mobile in breast. And because of its very high mobility in breast, it is also called breast mouse. Because of its very high mobility in breast, it is also called breast mouse, right? And now, what are the clinical features which, if there, will point toward a phalloid tumor? This phalloid tumor, in your given question, will be told having a variable consistency. It has a variable consistency. Second, it has irregular or bossylated or variegated surface. This is a very, very important clinical clue. If any of these are provided in a given question, it is phalloid tumor. It is phalloid tumor. Irregular surface or bossylated surface or variegated surface. Bossylated मतलब ऐसे एक आपको जब आप फील कर रहे हो तो आपको ऐसा लग रहा है कि खूब सारे लंप हैं, मतलब multiple irregularities हैं, right? So then it is also mobile in breast and it also has a well-defined margins. So that means margin and mobility will not be able to help you. What is going to help you is size and the consistency and the irregular surface and the shape, which gives it a asymmetrical shape, right? Now, in this, confirmation of diagnosis will be by ultrasound, and if by any chance you do a mammogram in a fibroadenoma, you will get a popcorn calcification. You will get a popcorn calcification, right? Now, in case of a fibroadenoma, now listen to this in treatment. Listen to this in treatment of a fibroadenoma. What the guideline says on treatment of fibroadenoma, then I'll make you understand that how will we answer in a given question. There was one of the students was asking me a question also. Who was that? About a fibroadenoma. So now check whether you can answer the question or not. Listen to the thing, then try to answer, and if you could not answer, let me know. Okay. Now the guideline says fibroadenoma should be observed. Guideline says fibroadenoma should be observed. But if the patient is apprehensive about this lump, one should excise it. Now, how will we apply when a given question comes to us in exam? If you are asked, what is the treatment of choice of fibroadenoma in general? Your answer is going to be observation. But if by any chance you are asked, what is the treatment of choice of fibroadenoma more than 2 centimeters specified? Then, because since once the lump is more than 2 centimeters in size, majority of the females gets apprehensive because of this and they opt for excision. So, then the answer will be excision. So that means if it is less than 2 centimeters in size, or in general, if it is asked what is the treatment of choice? Observation. But then if the female is apprehensive, even if the tumor if it is less than 2 centimeters, we have to excise it. It is about the apprehension of a female. So if the female in general less than 2 centimeters, females are mostly settles with the thing that you don't need to worry, just observe. But if the female says no, I want to get rid of it, even then what is the guideline? Fibroadenoma should be observed. But if the female is apprehensive, it should be excised. So this is what I am saying. So even if it is less than 2 centimeters, once the female is apprehensive, you have to still offer excision, even if it is less than 2 centimeters. But in general, more than 2 centimeters, females will not agree to observation, they will opt for surgery. Got it? Okay, no, your question is very good. It's a valid question, right? Now, in case of phyllioid tumor are primarily benign tumors. Phyllioid tumor is primarily a benign tumor, and the treatment of phyllioid tumor is wide excision with 1 centimeter margin. But please understand one very important thing. Sometimes we can have a borderline. Sometimes we can have a borderline malignant phyllioid tumor also. Sometimes we can have a borderline. Usually phyllioid tumor is benign, but sometimes phyllioid tumor can have a malignancy in it also. When it is malignant, it is called cystosarcoma phylloids. It is called cystosarcoma phylloids. If it is a borderline malignant phyllioid tumor or cystosarcoma phylloid, which was earlier referred as giant fibroadenoma, which was earlier used to be called giant fibroadenoma. This term is no more used now, but you may still find in the previous edition books a giant fibroadenoma written. So, giant fibroadenoma was a term earlier used for a cystosarcoma phylloids, and in a borderline malignant phylloids, the treatment is wide excision with 1 centimeter margin followed by radiotherapy. And please highlight it in your notes. Lymph node dissection has no role in phylloids tumor. Lymph node dissection has no role in phylloids tumor. Lymph node dissection has no role in phylloids tumor, right? Then comes borderline malignant phylloids tumor. also earlier called cystosarcoma phalloid, and cystosarcoma phalloid are also named as giant phagocytoma. So these terms are no more now used. The term used is borderline malignant. Okay, and the treatment of a borderline malignant phalloid tumor is wide excision with 1 centimeter margin followed by radiotherapy, and there is no role of lymph node dissection in phalloid tumor. Why there is no role of, the question is why there is no role of a lymph node dissection? अगर अब वो कह रहे क्यों नहीं करता बताओ? इसलिए नहीं करता, नहीं इसका भी रीजन है। अब पूछा है तो पूरा सुनो। मैलिग्नेंसीज पैथोलॉजी हो गया Malignancies mainly spread by lymph node. Sarcomas mainly spread by blood-borne route. Sarcoma spread by blood-borne route, and it's a sarcoma. And in sarcoma, since there is no lymph node spread, there is no role of lymph node dissection. है ना? ठीक है? Now, then comes intraductal papilloma. In this intraductal papilloma, there is a polyp-like growth. In this intraductal papilloma, there is a polyp-like growth in single duct. Most common age of presentation of this condition is 30 to 50 years. Most common presentation here is nipple discharge, and in this the nipple discharge is blood stained. And please note this point: intraductal papilloma is the most common cause of blood stained discharge from single duct, and it is also a most common cause of blood stained discharge from nipple also. It is the most common cause of blood-stained discharge not only from a single duct, it's the most common cause of blood-stained discharge from nipple itself. Okay, so if you are asking the most common cause of blood-stained discharge from nipple, the answer will be intraductal papilloma. And confirmation of diagnosis of this condition will also be by electrogram or ductography, and the treatment of choice for this condition will be थोड़ा slow. Okay. थोड़ा स्पीड कम करनी. ओके, शुरू से शुरू. Intraductal papilloma, most common age of presentation. अब मैं सुनाऊंगा. Most common age of presentation 30 to 50 years. Most common presentation nipple discharge. Most common discharge from nipple. So long blood stain discharge. Okay. And it's a most common cause of not only a blood stain discharge from single duct, it's a most common cause of blood stain discharge from nipple also. Confirmation of diagnosis here also is going to be by a galactogram. And the treatment of an important point to note in this condition is, this is very important point, intraductal papilloma is a proliferative condition, but it has क्या कर दिया? क्या करते रहते हैं? Intraductal papilloma. Now then comes mastitis. Mastitis. What do you understand by mastitis? Inflammation of the breast. Okay, now what is important here to understand? This inflammation of the breast is a forerunner of breast abscess. If you don't treat this condition, the patient may progress to breast abscess also. So once a breast abscess is there, breast abscess is always preceded by a mastitis. So if you don't treat mastitis, the patient will progress to breast abscess. So what is mastitis? There are two types of mastitis. Lactational mastitis, which is also called purpural mastitis. Lactational mastitis is also called purpural mastitis. There can be a non-lactational mastitis also, which is also called non-purpural. Out of the two, can anyone tell me which is more common? Lactational mastitis is more common than a non-lactation. Now, very, very important question. What is the most important predisposing factor for lactational mastitis? Lactation. Very good. And what does that lead to? Stasis. Very good. The most important predisposing factor is milk stasis. And if a female has a milk stasis and on top of it, if there is a cracked nipple, because females should understand and know that nipple hygiene is very important during lactation. If the nipple is kept dry, it can develop cracks, and through those cracks in the nipple, there is the bacteria from the mouth of the baby get lodged into those cracks. So there was a question asked, what is the most common organism involved in lactational mastitis? It is Staph aureus. And there was a question also asked that what is the source of this Staph aureus? The source of this Staph aureus is mouth of the baby. The source of this Staph aureus is mouth of the baby. Now, how does a female is going to present to us? The most common presentation of these patients will be breast pain, and very, very important point in this breast pain is the nature. The nature of this pain will be a throbbing type of pain. It will be a throbbing pain. So, moment you find a throbbing pain mentioned, start thinking about a mastitis or a breast abscess, right? Patient will also have enlargement of the breast. Patient may also have fever. Patient will also have a fever. On examination of these patients, you will find enlarged, engorged, tender, breast. You may find enlarged, engorged, tender breast. And very important to note, these patients may also have a peau d'orange appearance, which is also called orange. And very, very important, if you can recall, we talked about this orange peel appearance in carcinoma breast also. And once there is an orange peel appearance in carcinoma breast, it is a skin involvement. So what is this orange peel appearance? Answer in your MCQ source is not right. The reason of this orange peel appearance is very commonly asked question. It is in exam. It is due to subdermal, very good, subdermal lymphatic obstruction. The reason of this orange peel appearance is subdermal lymphatic obstruction. Whenever a subdermal lymphatic gets obstructed, either by a malignant cell or by a inflammatory cells here, a patient can have this appearance. Okay, now listen to this very carefully, and this is going to be applicable. This is going to be applicable in any such situation, and this you should understand as a rule. Whenever we have any acute infective condition, this is a rule. In any acute infective condition, is it an acute infective condition? Yes or no? So it is not only in this condition, it is applicable in any acute infective condition. We should first, immediately, we should start antibiotics. And since Staph aureus is the organism involved, a preferred antibiotic is amoxicillin with clavulanic acid. This was the question asked in your exam, right? And very important point, in a patient who has a lactational mastitis, should we stop breastfeeding or should we encourage breastfeeding? We should encourage female to empty her breast. Right? Now, you can appreciate this. Moment you start this, if the patient comes to you in a stage of mastitis, inflammation, most of the time, these patients will respond to this treatment. Most of the time, these patients will respond to this treatment. So, patient improves. So, the patient is improved. So, what will you advise? You will continue with this. You will continue with this, and you tell her to take a good care of the nipple, and you should also encourage her to regularly empty her breast, and you should also advise tight undergarments. You should advise her to wear tight undergarments of breast support along with antibiotic and frequent emptying of her breast. This is the advice you are going to give once the patient improves. If the patient fails to improve with this, it means the patient is progressing towards an abscess. If the patient fails to improve on this, improve के बाद same treatment continue, and you will advise her a tight undergarment, and you will teach her a right nipple hygiene also, right? If it fails to improve, that means it is progressing towards an abscess. Now you have to confirm this by doing ultrasound. If ultrasound confirms that it's a breast abscess, if the ultrasound confirms that it is a breast abscess, the first line of management now, the antibiotic will continue, mind it. You will not stop antibiotic, the antibiotic will continue, but the first line of management now, as per the latest, is what drainage? Percutaneous aspiration or drainage. Earlier, for breast abscess, we were doing incision and drainage. Now, as per the latest, we should first do a percutaneous aspiration or drainage, multiple attempts of this, at least 5. multiple attempts. If it fails, then if this percutaneous aspiration fails, then you should offer incision and drainage of this breast abscess. Then you should offer incision and drainage of this abscess. Understood? Understood? Okay. Then the last thing here in our discussion on breast. Is the speed fine now?
Yes, sir.
At the back, speed is fine? Speed is fine? Fine? Then comes, any question? Chale aage? Huh? Then comes Mondor's disease. What is Mondor's disease? Non-lactation management saying. Mondor's disease is superficial thrombophlebitis. It's a superficial thrombophlebitis of chest wall veins. It is a superficial thrombophlebitis of a chest wall veins. Now, how does a patient presents? This is a very classical, most common presentation of these patients. Most common presentation of these patients is painful. Most common presentation of these patients is painful, cord-like swelling in breast. Painful, cord-like swelling in breast. On examination, you will find tender, cord-like structure, cord-like structure in the skin of the breast. Now, this condition, please understand, this condition is a self-limiting condition. It will resolve on its own. What you have to just do in these patients, which they will ask you, the treatment of this condition is anti-inflammatory drugs, a symptomatic treatment with restriction of arm movement. Anti-inflammatory drugs with restriction of arm movement is what you advise to these patients. And this is all about our discussion on breast. Now, any question? Because once the arm movement keep happening, the skin will get stretched. So because of that, the inflammation will keep building up. You were asking some question. Chale aage. So now let us talk about trauma and get traumatized. Get further traumatized. The name itself has a superficial. Which type of vein? Which type of vein? Mainly the vein involved is lateral thoracic vein. It can also involve thoraco-epigastric vein. they will not check you on that. Don't worry. चले आगे. Now, let us talk about trauma. So, first of all, let me tell you here, trauma is a very important topic. You all know already now. And trauma questions are going to be very tricky. If you don't understand the concept, we will always be struggling to answer a question on trauma. And whatever we are supposed to, whenever we answer a question on trauma, we should always answer question according to ATLS guidelines, Advanced Trauma Life Support Guidelines. And whatever we'll be talking here will be according to the latest ATLS guideline. I'm an ATLS instructor at AIMS Trauma Center. So whatever we'll be talking here will be according to the latest guidelines. Okay. And please, and I told you in the beginning of our class also that you are here to clear your doubts. If you are not understanding something, at any point of time, you can stop me and ask question. Don't please hesitate in asking a question, because trauma questions are not going to be straightforward questions. They will be questions with a lot of twist inside, and you have to appreciate that twisting point. Okay. So now let us talk about trauma. First of all, can you tell me what is the most common trauma? Most common trauma is actually an emotional trauma. After emotional trauma, it is RTA. Right? Now, then comes what is triage. Now, one very important point in understanding of a trauma, listen to this carefully. One primary objective in management of a patient of trauma is a basic objective on the basis of which we manage a patient of trauma. And that basic objective is, the primary objective is, living problem is better than a dead solution. Living problem is better than a dead solution. So our primary objective in management of a patient of trauma is to save life. Whatever consequences we are going to have after saving life, we'll see later. Our primary objective is first and foremost is to save life. Right? And how are we going to save life? How are we going to go about in that? Is what we are going to discuss now. Now, can you tell me what is triage? To label the patient. Very good. Very good. Triage is, the literal meaning of triage is to sort. The literal meaning of triage is to sort. Now what's to sort? What is triage? Let's understand. Prioritizing treatment on the basis of severity of injury. Now, please, this is a very important understanding, and many students have cross issue on that. Can you tell me what is polytrauma? Multiple trauma. Polytrauma is, in one patient there are multiple injuries. In one patient, multiple side injuries if there, it is polytrauma. Okay, please understand what is polytrauma first, and then when you finish your MBBS, we are supposed to take an oath, the Hippocratic oath, and in that Hippocratic oath, it is specifically said that we should never prioritize. Every patient should get an equal importance. We should never prioritize. But here in triage, we are saying prioritizing the treatment. So why are we prioritizing them if we are told not to prioritize? Terms and conditions apply. The reason we should never prioritize. We should never prioritize. But the issue of prioritization comes when we have a limited resources and the demand is more. If the resources are less and the demand is more, we are left with no choice but to do triage. Now, this kind of a scenario where you find yourself falling short of resources comes most of the time in mass scheduling. Mass scheduling, like earthquake, like train accidents, like bomb blast. So these are the scenarios where we most of the time fall short of resources and we are left with no choice but to offer triage. Now, can anyone tell me, answer in your MCQ source is wrong, and you should be able to make out what is wrong answer in this understanding which you are having here. Should we do triage in polytrauma? There is no need. There is one question where they are asked, in which of the following condition you do a triage, and answer given is polytrauma. So you should understand that in polytrauma we don't need to do triage. The triage only comes into play when we have limited resources but the demand is more. Now, on the basis of triage, as she was rightly telling, that we are supposed to give tags, right? So we give tags to the patient like red tag. What are the various types of tags here? Red tag, yellow tag, and black tag. Very good. See, just knowing this now will not suffice, because you have to understand that who will get a red tag, who will get a black tag, or yellow or a green tag. First is red tag. Red tag is given to one who has a immediate life-threatening injury. Red tag is given to one who has an immediate life-threatening injury. Yellow tag is given to one who may have life-threatening injury, but not immediate enough. Who may have a life-threatening injury, but not immediate enough. Green tag is given to walking wounded patient. Green tag is given to walking wounded patient, and black tag is given to moribund, pulseless patient. About to die is the immediate life-threatening one. So please understand this. Okay. Now, let me tell you the funny part of it. When the first edition of ATLS guideline came, instead of term tag, the term used was label. So then they eventually realized we should not be giving a red label, black label, green label to an injured patient. So now it is red tag, black tag, yellow tag, and a green tag. Now, just knowing this, the kind of question we are getting these days in exam is not going to suffice. We have to know the clinical part. How will you decide that this patient should get a red tag, this patient should get a yellow tag, this patient should get a green tag, this patient should get a black tag? तेरा कुछ नहीं हो सकता, तो black tag पकड़, तू थोड़ा sick लग रहा है, तू red पकड़ ले, तू अभी थोड़ा ठीक है, तू yellow पकड़. How are you going to decide? Or you are going to throw these tags like this? Experience. So, visual examination. Otherwise, other conditions don't we do visual examination? Other condition में visual examination करते हैं, यहाँ पर हमने tag दे दिया तो. Okay. Let me rephrase it. This was a similar scenario asked in one of your exam, not in your exam, but in a NEET exam. The question goes like this. Imagine you are called to attend an emergency where 4 construction workers were working and the roof fell on them. Right? The moment you open the door, you have 4 patients in front of you. Tum akele, patient 4. Both minds are good. Limited resources, more demand. So obviously, triage. One of the patient is lying upside down and not moving at all. Another patient is lying in pool of blood and crying for help. Baaki to sun lo. Lying in pool of blood and crying for help. Third patient is having a severe maxillofacial trauma. And the fourth severe maxillofacial trauma. And the fourth one is shouting, ये material किसने supply किया था बुलाओ उसको मैं देखता हूँ. Who will you attend first? You will attend fourth one first. पहले का टैक्स तो देना, पहले उसको सेटल करें कि तू पहले बाहर जा. मतलब अपना टाइम उसमें लगा दे. तो कह रहा मैं नहीं जा रहा. अगर जा तो आपस की लड़ाई शुरू कर दे. What will you do? Whom will you attend first? Remember, this is the thing in trauma which you have to engrave here. This is what they keep checking in your exam also. It is said that whatever you do in trauma, you should talk, you should walk, you should eat. Whatever you do in trauma, you should always do it in A, B, C ways. Anybody whose airway is at risk is going to die first. Anybody who is breathing has a problem will be the second one. And the one who has a circulatory problem will be the third one. So, up this understanding say, you can easily make out whom to attend first. We have to attend the third patient first. Because he has a severe maxillofacial trauma, so his airway is compromised. Now, triage, important, is a dynamic thing. Triage is a dynamic thing. Once you have taken care of a red tag patient, your yellow tag patient should become red tag. Once you have taken care of all the yellow tag patients also, your black tag patient should become red tag. It's not that आपने किसी को black tag दे दिया, तेरा कुछ नहीं होगा तो उसका कभी कुछ नहीं होगा. You have to go to a black tag patient also, but only after you have taken care of red and yellow tag patients. Right? So this is the thing in trauma which you have to engrave. Right? So in any given question, in any triage scenario, you will be checked, you can be checked. So you should know how will we decide whom to attend first. Now, then comes, you have decided that this patient I should be attending first. Right? And once you have decided that this patient should be attended first, we have to conduct first primary survey. There is something called primary survey. And once your primary survey is over, then only we will proceed to secondary survey. Then only we will proceed to secondary. So what is primary survey? Primary survey is a swift examination. Primary survey is a swift examination. Very commonly this question comes in exam also. Primary survey is a swift examination to find what is killing. Primary survey is a swift examination to find what is killing and to take care of that. Primary survey is a swift examination to find what is killing and to take care of that. And secondary survey is an elaborate head to toe examination. Secondary survey is an elaborate head to toe examination. And please understand this basic point. We just cannot proceed to secondary survey till the time we have not taken care of what is killing. जब तक आपका ये taken care नहीं हो जाता, once a patient is not out of danger of what is killing, we just cannot think of doing an elaborate examination of the patient, because living problem is better than a dead solution. Now, in this primary survey is always conducted in a systematic manner. What is that systematic manner? We have to engrave again here. And that systematic manner is A, B, C, D, and E, always in this order. A, B, C, D, and E, always in this order. Now, can anyone tell me what A stands for? A doesn't stand for airway. What A stands for then? What A stands for? What A stands for? Airway. A stands for airway with important point, with restriction of cervical spine movement. Airway with restriction. It is not only airway. Please understand. It is airway with restriction of cervical spine movement. B, you all know, stands for breathing. C, you all know, stands for circulation. And D, you all know, stands for disability. And E stands for environmental. E stands for surrounding. ये कैसा E है? Environmental exposure. सर भावनाओं को समझो, हैं? कवि की भावनाओं को समझो. Environmental exposure. So A stands for airway with restriction of cervical spine movement. B stands for breathing. C stands for circulation. D stands for disability. E stands for exposure. Now, imagine, very important question. Imagine you are called to attend an emergency. Very important approach. You are called to attend an emergency. What will be your first step? सबसे पहले क्या करोगे? The first thing you should do is scene safety. What is this scene safety? Imagine you have a patient in front of across in a room, got trapped in a fire. You went inside and you started doing ABCD there. So you had one patient earlier, now two. You have a patient on the roadside, you started doing ABCD on the road. Now two. So always make the scene safe first. And this scene safety is for whom? For you. For the rescuer. For the rescuer. After scene safety, what will you do? After scene safety, we have to check response. After scene safety, we have to check for the response. And if the patient is not responding, you are not Rajnikant or Bahubali. That you will be able to do everything all alone. You will need help. So then call for help. 911 is for US. इंडिया का पता नहीं, US का नंबर मिला यहाँ मिलता ही नहीं नंबर, आप मिलाते रहे सेंट्रलाइज नंबर की. Anyway, so scene safety, check for response and call for help. अब आई बात बहुत इंपॉर्टेंट, हमें एयरवे विद रिस्ट्रिक्शन ऑफ स्पाइन मूवमेंट करना है. ठीक है, हम एयरवे के लिए क्या कर सकते हैं, अभी करते हैं। और हम see, listen to this point first. We have to understand. We have to restrict the movement of the cervical spine, and we have to do something about the airway also, right? First of all, how are we going to decide that the patient needs a airway help? Whether the patient needs a airway support or not. First of all, okay, let's start from the very beginning. See, what we first need to understand this ABCD approach, which is a very important concept, which is checked in your exam too. This is a very swift examination, but at the same time very systematic. In your exam, they commonly give you this kind of a confusing scenario, and we commonly get carried away to that confusing scenario also. This concept of ATLS guidelines says we have to do primary survey always first, and in that we have to follow A, B, C, D, E. Now this is a swift examination, but at the same time very systematic. If A is not a problem, we should immediately go to B. If B is not a problem, we should immediately go to C. But if A is a problem, even if there is a B and C evident problem in your given profile, you just cannot go to B or C till the time you have not taken care of A. And very commonly in your exam, they gave a profile. A patient has a road traffic accident and he is bleeding profusely from the wound, and he is in hypertension, and very subtly they'll tell you that the patient has a cyanosis also. And you start thinking about a control of the bleeding, so you will immediately start doing things for a bleeding control. And you forget that you don't come to C without going through A. So it is always A first. If A is not a problem, then B. If B is not a problem, then C. But if A is a problem, you can't go to B. You can't even think of going to B, leave alone going to C. Understood? Okay. Now, so that means we should always have, we have to take care of airway, and we have to take care of the spine also. Okay. And subject to condition, patient needs some airway support, right? If the patient doesn't need an airway support, why would we do anything about airway? Patient को airway की problem ही नहीं है, so why would we do airway support? So first of all, this is a very, very important understanding. In any given question, always try to figure out that. And what is that? It is said that any patient who can speak, any patient who can talk, airway is not a problem there. So in any given situation, we have to immediately after call for help, assess whether airway has a problem or not. To assess airway has a problem or not, you should talk to the patient. Immediately, next, talk to the patient. Ask any question. And obviously, a relevant question. Not who is the Chief Minister of Jharkhand. Tell me. Even in your senses, you will not be able to answer, leave alone a trauma scenario. So, the basic question is name. You should ask patient's name. So, imagine patient has responded. Patient has spoken some word. It means airway is not a problem. We can immediately go to B. We can take it for granted that A has no problem, so we can go to B now. But imagine patient has not responded. Right? Patient has not responded. You try to speak to the patient, patient has not responded. There can be 3 reasons for patient not responding. 1, patient has an airway problem. Because of the airway problem, patient may not respond. Second, patient has a head injury. Patient has a head injury. The command is not coming. That can also be the reason. And third, patient doesn't want to respond to it. Patient doesn't want to. It happens, you know. When you join your internship in casualty, you'll find many times this happens at the middle of the night. Most of the time, females. You do whatever, they will not respond. Hysterical functional patient. So how will you know this patient is not responding? Is because of an airway problem, or is because of head injury or doesn't want to talk to me. So we should be able to pick the points in the given profile of a question, whether the patient has an airway problem or not. So what are the signs of airway problem? We should know. The signs of airway compromise are, the signs of airway compromise are 1. Tachypnea. 1. Tachypnea. This is the earliest sign. Tachypnea is the earliest sign of airway compromise. Second, use of accessory muscles of respiration. Use of accessory muscles of respiration. Third, snoring, gurgling, hoarseness, or stridor. Fourth, if there is a tracheal shift or if the patient has a cyanosis, this is a late sign. So if any of these are there in a given patient and the patient is not talking to you, means patient has some airway problem. So that means we can't go to B now. समझ आ रहा है सबको? That means we can't go to B now. We have to stay at A. एक कार में चार आदमी. तो देख रहे हैं ना? अब इस क्वेश्चन इज कि कार में 4 आदमी है और चारों को इंजरी हुई है, and in that both of them has a airway problem. You are all alone. तो अब क्या करें? तो आप यहाँ पे क्या करेंगे? पहली बात तो आपको ऐसा सिनेरियो मिलेगा नहीं एग्जाम में, ठीक है? और ऐसी सिचुएशन में आपको अब दोनों ही रेड टैग है. ये क्वेश्चन इज दोनों ही रेड टैग है, हम क्या करें? ये क्वेश्चन है ना. अब दोनों ही रेड टैग है तो आप क्या करोगे? आपको यहाँ पे आप यू कैन नॉट डिसाइड. दोनों को एयरवे प्रॉब्लम है, एक करके आपको. अब आप तो अकेले हो, बाहुबली तो हो नहीं या रजनीकांत तो हो नहीं, तो आपको पहले एक को सेटल करना और फिर उसके बाद दूसरे के पास जाना. आपके पास कोई चॉइस नहीं. बट आपको इन एग्जाम्स यू विल नॉट गेट दिस काइंड ऑफ अ सिनेरियो, राइट? बट दिस इज अ प्रैक्टिकल प्रॉब्लम. दिस कैन हैपन, बट देन देयर इज नो सॉल्यूशन टू दिस. You have to take a call out of the two which you think has a better chance of survival. Okay, चलें आगे. So if these are there, patient has an airway problem, right? Now we have to take care of airway. We have to take care of cervical spine also. Now how are we going to take care of the airway? How are we going to take care of the airway? How are we going to take care of the airway, and how are we going to take care of the cervical spine? We have to know. Airway, first of all, cervical spine. We can take care of cervical spine in 2 ways. We can take care of cervical spine in 2 ways. One is Mills, and another is cervical collar. We can take care of the cervical spine in 2 ways. One is Mills, another is cervical collar. What is Mills? Manual in-line stabilization. Manual in-line stabilization. And what is the cervical collar? The cervical collar used in trauma is called Philadelphia collar. Philadelphia collar. It's a semi-rigid collar. It's a semi-rigid collar. Okay. Now for taking care of the airway, we have chin lift, jaw thrust. We have chin lift, jaw thrust. We can lift the chin. Okay, sorry. Don't you are telling me in between because मेरी थोड़ी सी कभी-कभी मैं भावनाओं में बह जाता हूँ, तो मुझे रोक देना. cervical collar which we use is Philadelphia collar, which is also a semi-rigid collar. Okay. Ab chin lift or jaw thrust, right? This is one of the way of taking care of the airway. What is chin lift? You lift the chin like this. Jaw thrust is you lift the jaw. You pull the jaw. So chin lift or jaw thrust, right? Then नहीं ये tongue prolapse को रोकने के लिए when the patient is dying, you will pull the jaw and put it forward, right? Now then we also have for airway support we have endotracheal intubation. For airway support, other than chin lift and jaw thrust, we have the support in the form of endotracheal intubation. We have surgical precothyroidotomy. We have tracheostomy. We also have oropharyngeal airway. Anesthesia हो गया तो फिर तो मेरे लिए आसान है काम. Oropharyngeal airway, हाँ? Nasopharyngeal airway, oropharyngeal airway, laryngeal mask airway. These are the airway supports we have. Now, please, this question keeps coming, and also multi-lumen esophageal tube. So these are the various things we have in hand to take care of the airway. Now, in this, very important, we should know this. These three are called definitive airway. So you can be asked, which of the following is not a definitive airway? Which of the following is not a definitive airway? So you should know what are the definitive airways we have. And these chin lift and these are called adjunct airways. Chin lift, jaw thrust, oropharyngeal airway, nasopharyngeal airway, laryngeal mask airway, multi-lumen esophageal tubes. These are called adjunct airways. Okay, so you can be asked that which of the following is an adjunct airway, so you should know these are the adjunct airways we have. Now, can anyone answer this question? We have to take care of airway also. We have to take care of the spine also. Out of airway and cervical spine, which is your priority? Spine. Very good. It is always airway. It is always airway. So airway is a priority over spine. Airway as a priority. Please note एक और point. Listen what देखो बहुत important बात मैं बोलने वाला हूँ. अगर हमसे पूछा गया out of airway and cervical spine, which is your priority? Your answer will be airway. No confusion, right? But if you are asked out of airway and cervical spine, maintenance of airway is your priority. Maintenance of airway is your priority or cervical spine. अब question change हो चुका है. We maintain airway by a definitive airways. Okay. So if the question says maintenance of the airway or cervical spine, which is your priority, the answer will change to cervical spine. We don't put endotracheal tube without taking care of the cervical spine. But out of airway and cervical spine, always airway. Why airway is a priority or cervical spine? हम जो first encounter कर रहे हैं patient से, where we are talking to the patient and trying to assess airway, is nothing but is actually the airway thing which are doing. So airway is always as a priority over cervical spine, but maintenance of airway is always after cervical spine. Maintenance of the airway we do by these maneuvers which I mentioned, right? So please understand that airway is always a priority over cervical spine, but maintenance of airway comes after. Understood, everyone? Now, another very important point. This is also a clue in your given question. If that clue is there, you have to do that. What is that? If in any given question, so we have understood that if the patient is not talking to us, if the patient is not speaking, and any of these signs are there, we understood that the patient needs airway support. We understood that the patient needs airway support, everyone. Now in airway support, the definitive airway, you have to put once the GCS of the patient is less than or equal to 8 as a rule. What is this GCS we'll be talking about? We'll be discussing that. Any patient in a given question, if you are told as a GCS of 8 or less than 8, you cannot go to B without putting an endotracheal tube. You cannot go to B without putting in an endotracheal tube. Or oxygen saturation of the patient, is less than 85% on oxygen. Oxygen saturation of the patient, if in any given scenario in your question you are told that oxygen saturation of the patient is less than 85% with oxygen going on, patient needs endotracheal intubation as a rule, right? So what we have understood, let me summarize it. In any given question, if the patient is talking to you, you should be proceeding to B. If in any given question, patient told is not talking, or if you are told that patient is not talking and these signs are there, cyanosis is told to you, patient is having a gurgling, snoring or hoarseness of voice, these are the findings which suggest that the patient has an airway problem. And once the patient has an airway problem, we have to stay at A. And out of airway and cervical spine, priority is always airway. However, endotracheal intubation or maintenance of airway will be always after cervical spine protection. And how will you protect cervical spine? Either by Mills or by cervical collar. Either by Mills or by a cervical collar. Now, how will you decide whether the patient needs an intubation or not? If any of these two are there, you have to put in an endotracheal tube and then only you can proceed to B. Understood? So any patient who has GCS of less than 8 is a candidate of endotracheal intubation. Now once you have taken care of A, imagine, this was also one of the questions. You have put in an endotracheal tube. Must have been discussed in your anesthesia class, I don't know. Once you have put in an endotracheal tube, what will be your immediate next step? Check whether it is in the lung or in the esophagus. So how will you check? 5-point auscultation. we should do 5-point auscultation. And they ask this question, what is the first point in that? Where will you put a bell of the stethoscope immediately after putting in a tube? You should immediately put in a bell of the stethoscope on the epigastrium. On the epigastrium of the of the patient, obviously. Right? Epigastrium of the patient, and then 5-point auscultation. Epigastrium, right and left upper chest, right and left lower chest. Epigastrium, right and left upper chest, right and left lower chest. And how will you confirm that your tube is in the airway? Bubble is not a confirmation. I am talking about a confirmation. These are the suggestion that your tube is in the airway. The confirmation of an airway intubation, very commonly asked question it is. Must have been discussed in your anesthesia also. It is capnography. The confirmation of airway intubation is capnography. Now, once you have taken care of airway, then only you should proceed to P. If anybody has a doubt, please ask. First point of auscultation is epigastrium. First point is epigastrium. Then right and left upper chest, right and left lower chest. Confirmation of airway intubation is capnography. This is not confirmation. This is just a yes. We can do a chest X-ray also. The question is not about whether the tube is in the trachea. She has asked a very good question. Can't we check on a chest X-ray? When the chest X-ray will be answered? Answer, chest X-ray will be there if you are asked, what is a confirmation of a tracheal intubation of the endotracheal tube? How will you know that your tube is in the trachea? The confirmation of that will happen with chest X-ray. But confirmation of airway intubation if asked, it is capnography. क्या फर्क है? नहीं, फर्क क्या है? What is the difference? See. Okay, let me explain. Probably this must have been discussed in the anesthesia classes also. They are better person to discuss this though. But then I'll try to make you understand this. The tube we are putting, where do we want to put it? We want to put it in the airway, right? We don't want to put it in the esophagus. So esophagus and trachea are the two tubes in the neck, right? So the endotracheal tube can go into the esophagus also, it can go into the trachea also. We want it to go into the trachea. Now, it will go to the trachea through the opening of the larynx. It will enter trachea through the opening of the larynx and then the vocal cord and then into the trachea. Are you understanding? Right? Now, the question is, what is the confirmation of an airway intubation? How will I know that my tube has gone into the larynx? The moment it enters larynx, the graph which you get on capnography must have been told to you in anesthesia classes. That graph you will get of graph of an airway. Right? Your tube is in the airway now. But we don't know whether the tube is just entered the larynx or has entered the vocal cords or has gone into the trachea. The position of this into the trachea is going to be confirmed by a chest X-ray. So confirmation of tracheal intubation if asked, it is chest X-ray, but confirmation of an airway intubation will be capnography because चाहे आपकी tube larynx के just अंदर है or your tube is in the trachea, the graph for capnography will be same, right? So that is a confirmation of an airway intubation. Understood? Okay. Then comes breathing. Now, in breathing, very, very important point. This is going to be a question. ऐसा कोई एग्जाम नहीं हुआ अभी तक, चाहे वो INICET हो, चाहे वो एम, चाहे वो नीट हो, चाहे FMG हो, जिसमें इस टॉपिक पे क्वेश्चन नहीं आया.
able to follow spine because in also almost all spines
follow ATLS. ATLS नहीं कहीं उल्टा नहीं होता, सब जगह पे एयरवे इंपॉर्टेंट बस आपको सिर्फ मेंटेनेंस एयरवे की सर्वाइकल स्पाइन के प्रोटेक्शन की बात करनी है, बट एयरवे हमेशा सर्वाइकल स्पाइन से प्रायोरिटी, इसमें कोई कंफ्यूजन नहीं, और ऑर्थोपेडिक्स में भी नहीं बताई गई होगी ऐसी कंफ्यूजन, यू हैव अ कंफ्यूजन, सो ये कंफ्यूजन निकाल दो कि सर्वाइकल स्पाइन इज मोर इंपॉर्टेंट देन एयरवे, एयरवे इज ऑन बट मेंटेनेंस ऑफ द एयरवे इज आफ्टर सर्वाइकल स्पाइन. Breathing. This question is ये छपा हुआ question. And what is that? In breathing, we have to see three things. In the breathing part, we have to actually see three things. What are those three things? Let's first talk about the first thing, and that's the most important thing actually. And that is tension. In primary survey, we have to identify that whether the patient has, in B part, whether the patient has tension pneumothorax or not. I hope you know what is tension pneumothorax. Yes or no?
Yes.
So in tension pneumothorax, the air is trapped in the pleural space in tension. Air, what is pneumothorax? Presence of air in a pleural space is pneumothorax. Presence of air in a pleural space is pneumothorax. There are two types of pneumothorax. Simple pneumothorax and a tension pneumothorax. Simple pneumothorax is not an emergency, mind it. Simple pneumothorax is not an emergency. It is a tension pneumothorax which is an emergency, which we have to address here itself in B. Simple pneumothorax, we don't have to address in B. We have to address tension pneumothorax in B. So we have to identify whether the patient, we have identified a patient who has an airway problem. How are we going to identify? We understood. Now we have to understand in a clinical profile whether the patient has a tension pneumothorax or not. So what profile of the patient will be there, which will tell me that the patient has a tension pneumothorax. What is tension pneumothorax? The air is trapped in a pleural space in tension. Let me draw this for you so that you understand. This is the thoracic cage. Imagine this is a chest wall, right? And imagine this is the lung. This is the lung. And this is the pleura. This is the pleura. Okay? The space between parietal and visceral pleura is pleural space. Now, air coming here is pneumothorax, right? And once the air is trapped inside in tension, it is tension pneumothorax. So what happens in a tension pneumothorax? The air here gets trapped like this. And once the air gets trapped inside, it will push lung, compress the lung first. The air, what happens in tension pneumothorax? Let me clear this to you. Moment patient takes a breath. Every time patient taking a breath, the air in the pleural space keeps increasing. Keeps increasing. Keeps increasing. So what will happen when it keeps increasing? It will first compress the lung. It will first compress the lung, and then it will compress the IVC and the superior vena cava also. And it will also push the mediastinal structure to the opposite side. But what happens in a simple pneumothorax? In simple pneumothorax, the air comes in the pleural space, but with every breath the patient is taking, it doesn't increase. Please understand this. This is a basic difference between a simple pneumothorax and a tension pneumothorax. In tension pneumothorax, every time patient is taking a breath, the air inside the pleural space keeps increasing. So that means every time patient is taking a breath, it is actually causing a problem further to the patient. So every breath is actually killing the patient here, because what is happening? It is compressing the lung. It will eventually compress the IVC. It will eventually compress the superior vena cava. Once it compresses the IVC and the superior vena cava, the venous return to the heart will decrease. When the venous return to the heart decreases, the cardiac output will decrease. When the cardiac output decreases, the patient develops hypotension and shock. And then eventually patient will die. Understood? So this is what is tension pneumothorax. Understood now? Now how? This is the pathophysiology. Now how the patient will come to me? How will I know that this is a patient of tension pneumothorax? A patient, let's together make out the presentation. Correct me if I'm wrong. In the profile of the patient will be talking to you, yes or no? Patient will be talking because it's not an airway problem. It's a problem of the lung. So it is not an airway problem. Okay, so one need to understand it is not an airway problem, it's a breathing problem. So these patients may be talking to you, right? But then what will tell you that there is a breathing problem here? The patient will have a respiratory distress. Yes or no? Yes. So that means this patient also will have a tachypnea. This patient also has a tachypnea, but in context of talking to you. In context of talking to you, if the patient is talking and having a tachypnea, we know this is not because of an airway. When the patient has a tachypnea and not talking to you, it means the airway problem. A patient who is talking to you, having a tachypnea, there is a breathing problem. Are you understanding what I'm saying? Okay. So this patient will be in a severe respiratory distress. Right? Agreed? Okay. Then, along with this, the patient will have hypotension. The reason of hypertension, I told you. The reason of hypertension, I told you. Now, can you tell me what will be the status of jugular venous pulse when the superior vena cava is getting compressed? There will be back pressure, so it will be increased. So JVP will be raised or the neck veins will be prominent. So in the clinical profile of the patient, you will be told that the neck veins of the patients are prominent, right? Despite having a hypotension. In hypotension, usually the JVP decreases, but here the JVP will be prominent. Now, can you tell me what will be the status of the breath sounds? When you put a stethoscope here, the air is there in the pleural space, lung is compressed completely. So what will happen to the breath sounds? Absent. Why would it be decreased? It will be absent. It will be absent. What will be the status of the percussion note?
Box sound.
Box sound. What is that box sound? घड़े में आवाज. तो अब ये तो लिखा नहीं, जब लिखा होगा तो क्वेश्चन में घड़े में आवाज आ रही है. हम क्या बोलेंगे इसको? So can I say hyper resonant or tympanic? Can I say that?
Yes.
अब एग्जाम में घड़े वाली साउंड तो लिखेगा नहीं, समझ गया मैं, बट वो tympanic बोलेगा, right? And what will be the status of the trachea? Trachea shifts to opposite side. So if any of these are there in a given patient, it is tension pneumothorax. So what will you do immediately? What will be your immediate next step? What is the investigation of choice here? What is the investigation of choice? What is the investigation of choice for tension pneumothorax? X-ray, chest. If you send this patient for chest X-ray, you will get a dead body coming back. Every breath patient is taking here is killing the patient. So diagnosis of tension pneumothorax is clinical. Diagnosis of tension pneumothorax is clinical. You don't have to do any investigation, mind it. If you send this patient for any investigation, you will get a dead body coming back. So what will you do immediately? You will put a needle. You will do a needle decompression. And where are you going to put this needle?
Sir, 6 to 7. 6 to 7.
We will put a needle in a fifth intercostal space anterior to mid-axillary line. And please be very, very careful about it. If in a given clinical profile, the patient is a pediatric patient, specifically in a pediatric patient only, your answer should be second intercostal space, mid-clavicular line. Second intercostal space, mid-clavicular line. But the definitive treatment here is chest tube placement. Definitive treatment here is chest tube placement. And where are you going to put a chest tube? Same. Fifth intercostal space, very good. Fifth intercostal space anterior to mid-axillary line. Same. Definitive treatment same hai. Only thing changes is the immediate thing. Right? And remember, whenever we put a chest tube, listen to this carefully, and this can be a question again in exam. We always put a chest tube in a triangle of safety. What is a triangle of safety? The triangle of safety is found by the anterior border of this triangle of safety is found by anterior axillary fold. Anterior axillary fold or lateral border of pectoralis major muscle. Lateral border of pectoralis major muscle. Posterior border of this triangle of safety is found by posterior axillary fold or lateral border of latissimus dorsi. Lateral border of latissimus dorsi, and the floor is found by fifth intercostal space. Floor is formed by a fifth intercostal space. Floor is formed by a fifth intercostal space. And very, very important point further, if this is the intercostal space, if this is an intercostal space, we should always put a needle or the chest tube on the upper border of lower rib. We should always put in a chest tube or a needle on the upper border of the lower rib. Why so? Because the neurovascular bundles are present in the lower border of the upper rib. Okay, right? So this is something we have to identify in B part of a patient always. Okay, then we also need to identify in the B part, there is something called, is a speed fine? If the patient is not speaking and there is a tracheal shape, then we will presume first aid. Yeah. चले आगे, right? Now, then another thing which we have to identify here in the B is sucking or open chest wound. Sucking or a open chest wound. What is this sucking or a open chest wound? If this is the thoracic cage, imagine. Imagine this is the thoracic cage, right? And what is sucking chest wound? Imagine the injury happened to the patient in such a way that there is avulsion of the whole of this region of the chest wall. The whole of the chest wall, like this, got avulsed. And now the pleural space is communicating with exterior. Chest wall, skin, muscle, ribs, everything got removed. And now the pleural space is communicating with exterior. This is called open or a sucking chest wound. So when you take a breath, you know that in your physiology you must have been told that when you take inspiration, our pleural pressure is negative. So what will happen because of this negative pleural pressure? The air will get sucked inside. Right? So every time patient is taking a breath, the air is getting sucked from there. So this is called sucking or an open chest wound. So in this scenario, immediate next step, very important, this can be a question again in exam, immediately cover this wound with a dressing. Immediately apply dressing over it, cover it, immediately cover it. But after covering it, this is something important. You should apply adhesive. You should apply adhesive on the 3 sides, like this. You should apply adhesive on the 3 sides like this, leaving one side open. You should not apply adhesive on all the 4 sides. You should apply adhesive only on the 3 sides, leaving one side open. Leaving one side open. Now, once you have done this in an open or a sucking chest wound, now you will put a chest tube. Now you will put a chest tube away from the site of injury. Now you will put a chest tube away from the site of injury. Once you have placed in a chest tube, once the chest tube is placed, now you will apply adhesive on the 4th side also. Now you will apply adhesive on the 4th side also. You should never apply tape on all the 4 sides without putting a chest tube. After putting a chest tube, we can apply adhesive on all the 4 sides. Why are we doing it like this? Because if we cover all the 4 sides up front, the air which was trapped inside will get trapped and it will lead to tension pneumothorax. So we will keep a vent for the air to go out and then put a chest tube and then proceed. Okay, so this is what we do in a sucking or a open chest wound. And third thing which we have to identify, we have to apply dressing immediately on this. And in this dressing, we have to apply adhesive on 3 sides. After applying adhesive on the 3 sides, we will put a chest tube away from the site of injury. Once you have put it in a chest tube, now you can apply adhesive on the 4th side also. Is the speed fine? Speed fine? Speed fine? Okay. Then comes the third thing which we have to identify in a B part is massive hemothorax. Massive hemothorax. The most common cause of massive hemothorax is checked in exam, injury to intercostal vessels. Most common cause of massive hemothorax is injury to intercostal vessels. Now, we have to identify the patient has a massive hemothorax or not. So what clinical profile of the patient will be there in a given question, which will tell us that this patient has a massive hemothorax, and once that profile is there and what to do, we should know that. Okay, so this patient of a massive hemothorax means, what is massive hemothorax? There is a gross amount of blood in the pleural space. There is a gross collection of blood in the pleural space. Okay, now, when there is a gross amount of blood in the pleural space, the lung will get compressed? Yes or no?
Yes, sir.
Okay. So, will this patient be in respiratory distress?
Yes.
Yes. So, that means this patient here also will be in respiratory distress. What will be the status of blood pressure? Will there be hypotension or not?
Hypotension.
There will be hypotension here also, right? And what will be the status of JVP here? It will be decreased because there is a bleeding happening. So JVP will be decreased. Now, what will be the status of the breath sounds? Breath sounds. Again, they will be absent, but can be decreased also, but more often than not, it will be absent. And what will be the status of the percussion note? What will be the status? Dull. Dull. And what will be the status of the trachea? Affected side. Blood aane pe. If pressure is very high, then it will be shifted to opposite. So can I write here? Correct me if I'm wrong. May not be shifted. Agreed? May or may not be shifted. So if you find any of these signs, so please be very, very careful to make out in a given question whether the examiner is checking you on a tension pneumothorax or the examiner is checking you on a massive pneumothorax. So once any of these are there in the given profile, we should immediately do what? Here, we will put in a chest tube. Here, we will immediately put in a chest tube. And where will you put a chest tube? Triangle of safety. Triangle of safety again, that is fifth intercostal space anterior to mid-axillary line. Understood? All of you? So please be very, very careful in a given question to identify whether the patient has a tension pneumothorax or the patient has a massive pneumothorax. Understood? Any question? Sure? Now, once you have taken care of the B, we will do now. See, it's a very valid question that what to do now. We will then come to C, no? So now we have to take care of the C. Circulation. Now, in circulation, first of all, let me tell you the theoretical points in this, and then I'll make you understand it. Okay. First of all, can you tell me what is the most common cause of shock in trauma? The most common cause of shock in trauma is hypovolemia, hemorrhagic shock. The most common cause of shock in trauma is hemorrhage leading to hypovolemic shock. Now, we should know this classification of hemorrhagic shock. This table which I am going to make is very high table for exam. So there is a class 1 shock, there is class 2 shock, there is class 3 shock, and there is class 4 shock also. Class 1 shock is called minimal shock. Class 2 shock is called mild shock. Class 3 is called moderate shock. Class 4 is called severe shock. What is mild, what is moderate, what is severe, and what is minimal, we should know. When the blood loss is less than 15%, when the blood loss is less than 15%, it is minimal shock. When the blood loss is 15 to 30%, it is mild shock. When the blood loss is 30 to 40%, it is moderate. If it is more than 40%, it is severe. Or if the blood loss is less than 750 ml, if the blood loss is less than 750 ml or 750 to 1500 ml or 1500 to 2000 ml or more than 2 liters. Now heart rate. Here will be less than 100, 100 to 120, 120 to 140, more than 140. Respiratory rate, less than 20, 20 to 30, 30 to 40, more than 40. Pulse pressure. What is pulse pressure? Pressure. Pulse pressure is the pressure. Yeah, got it. I thought volume.
SBP minus
Systolic. Systolic blood pressure minus diastolic blood pressure is pulse pressure. Systolic minus diastolic is pulse pressure. And it is normal or increased in class 1. It is normal or increased in class 1, decreases in class 2, decreases further in class 3 and class 4 shock. Systolic blood pressure less than or equal to 90. Systolic blood pressure less than or equal to 90 will not be there in class 1 shock, will not be there in class 2 shock, will be there in class 3 and class 4 shock. Right? Pace deficit. Pace deficit 0 to minus 2 milliequivalent per liter, minus 2 to minus 6 milliequivalent per liter, minus 6 to minus 10 milliequivalent per liter, less than minus 10. Right? In this requirement of blood, it is not there. Requirement of blood is not there in class 1 shock. Class 1 shock is like you donate blood to someone. Class 1 shock, no need of blood. Here, need of blood, possible. Here, yes. Here, always. Massive blood. Okay. Right? Very commonly in your exam, You have to appreciate these points in a clinical question provided. First of all, you will be told these terms are very commonly used in our clinical practice. Patient is stable, patient is unstable. When will you call a patient stable or unstable? Very good. Any patient having a systolic blood pressure of less than or equal to 90 will be considered unstable. Any patient having a systolic blood pressure of less than or equal to 90 will be considered unstable. Okay, now let me ask you. Imagine there is a bucket. Think about a bucket, and this bucket has a water. Okay, and now in this bucket, imagine there is a hole. The water is leaking out, right? Just imagine body like a bucket, and now the trauma has happened, leading to bleeding, and that blood is leaking out. Now tell me, how should I fill this bucket now? The bucket is getting empty. The bucket is getting empty. So how can I get back the normal level of fluid, the water in the bucket or the blood in the body? So that means she has asked a question that, sir, there is a patient who has a bleeding happening and we are putting in a chest tube. So we have to do something else also because the patient is losing blood. So we have to do two things. You already have answered that. One is control bleeding, and second, replacement of lost blood. These are the two things we have to do. Agreed? So in any patient of trauma, we have to control bleeding and we have to replace the lost blood and fluid. Now, out of the two things, now again, this was a question asked, and you can now apply your understanding which I'm trying to give you with assuming that there's a bucket and there's a hole. What is out of the two is your priority? Obviously, control will be your priority because if you keep on pouring water from outside, it's never going to get filled up till the time you plug that hole. So you have to plug the hole first. So in any trauma patient, this is the thing that we have to control the bleeding. Always. Okay, now we have to replace blood and fluid also. So how will we replace blood and fluid? So in every patient of trauma, now they say immediately in C, put two wide bore short length cannula. We have to immediately put in a two, not one, two wide bore short length cannulas. You all must be aware, 16 gauge cannula is gray cannula, 18 gauge cannula is green cannula, 20 gauge cannula is pink cannula. Okay, now you all must be aware, as this number is increasing, the diameter of the cannula is decreasing. So that means out of the three cannula which I have given, which one you will use? We should use the widest bore available. सुन तो लो क्या बोल रहा हूं मैंने क्या बोला? You should always use in a given question the widest bore available. तो इस इन तीन में वाइडेस्ट बोर कौन सा है? 16 है. अगर मैं यहाँ पे 14 गॉज ऐड कर दूं ऑरेंज, तो कौन सी यूज करूंगा मैं? तो इसका मतलब क्या हुआ, किसी भी क्वेश्चन में हमें उन 4 चॉइसेस में सबसे वाइडेस्ट बोर वाली ढूंढनी. हमें ये फिक्स नहीं है कि मुझे हमेशा ग्रे डालनी है या मुझे ग्रीन ही डालनी है. मुझे उन चॉइसेस में से जो वाइडेस्ट बोर पड़ी है वो उठानी है. मेरे पास जो इवन इन माय इमरजेंसी रूम आई हैव टू सी व्हिच वाइडेस्ट बोर इज देयर इन द इमरजेंसी रूम. Likewise, in a given choice also, you have to see which widest bore is provided. If orange is there in the choice, we will take orange. If orange is not there, then we'll take gray. If gray is not there, we'll take green. Okay. Now, you have to put 2 wide bore short length cannulas. No confusion. Many sources are giving different answer to this. You should not have any confusion. हमें जो widest bore है उसमें, whatever the widest bore provided in the given 4 choices, you have to pick that and start. Okay. Now, in a patient who is in trauma, who has a blood loss happening, many times veins may be collapsed. You may not be able to put a cannula because the vein is collapsed. So if you can't put a cannula in the vein, what will you do? Never central line. Never central line. What will you do? You will do intraosseous cannula. What is this intraosseous cannula? You have to put a cannula in the bone. Where will you put? Proximal 1/3 of shin of tibia. You should put a cannula in the proximal 1/3 of shin of, and please highlight it in your notes that you will never put a cannula in the great saphenous vein or short saphenous vein. So you should not put a cannula in the lower limb veins. Why? Why we should not put a cannula in a lower limb vein? Because these great saphenous vein and short saphenous veins are very important for us. Because in future, we may require a bypass. And if we require a bypass, these veins are the veins required. So if you spoil these veins with this, you will not have a vein left for a bypass. Short saphenous vein and great saphenous vein should not be used for cannulation. Understood? Internal memory we use for only a left anterior interventricular artery bypass. For rest other bypasses, we'll use a great saphenous vein. Intraosseous cannula. Right? Now you are putting in a cannula. अब cannula लगा के क्या करें? Celebrate करें? Now we have to start immediately 1 liter of. This is how we go about. Now listen to this carefully. Earlier it was said that in RC we should try to give blood and fluid in such a way that the patient blood pressure should come back to normal. Earlier it was said that we should try to give fluid and blood in such a way that the patient's blood pressure should come back to normal. But now they say don't try to do that. Do a hypotensive, which is called permissive hypotensive resuscitation. Now they say that don't try to raise blood pressure of the patient to a normal, because moment you raise the blood pressure of the patient to normal, more bleeding will happen. So you should try to maintain the blood pressure of around 90. Don't be after raising the systolic blood pressure of the patient to a normal level. Just try to maintain at 90. With this 90 blood pressure, the organ perfusion also will be adequate and the bleeding will also not get increased. So for this, what we will do? We will immediately put 1 liter of crystalloid. We will start immediately 1 liter of crystalloid. Which crystalloid? Either ringer lactate or normal saline. Commonly, we use ringer lactate. And after that, what we will do? We will give 1:1:1. What is this 1:1:1? Blood and blood products. What is this blood and blood products? Whatever amount of PRBCs you are giving, whatever amount of packed red blood cells you are giving, the same amount of fresh frozen plasma you should give. Same amount of fresh frozen plasma you should give. And same amount of platelet-rich plasma you should give. Whatever amount of packed RBCs you are giving, same amount of fresh frozen plasma you should give, and same amount of platelet-rich plasma you should give. So in the ratio of 1:1:1. Whatever unit of packed RBCs you are giving, same unit of fresh frozen plasma you should give, and same unit of platelet-rich plasma we should give. And now they say, if the patient comes within 3 hours, only when the patient is received within 3 hours, not after that, we should also give tranexamic acid. We should also give tranexamic acid if the patient comes within 3 hours, not after that. What is tranexamic acid? It is anti-fibrinolytic agent. Right? Immediately, within 3 hours, if the patient is coming, we should also give tranexamic acid. Right now, so if you are asked, what is the fluid of choice in trauma? There is no confusion about it. It is ringer lactate. But if you are asked, what is the best fluid in trauma? Khoon ke badle khoon. Best replacement of blood loss is blood. Best replacement of blood loss is blood. Now, which blood? Obviously, human blood. So, which blood is preferred? Very commonly asked question. The preferred blood is always, without any confusion, cross-matched blood. Cross-matched. What is cross-matched blood? Very good. So you know what is cross-matched? Okay. So always cross-matched blood. Cross-matched blood क्या होता है? See, there are two things. There is something called grouping. There is something called cross-matching. ग्रुपिंग का मतलब है, अगर मेरा ब्लड ग्रुप O पॉजिटिव है, तो ब्लड बैंक में जो O पॉजिटिव ब्लड पड़ा है, there is a O positive blood present in the blood bank, so they will give the O positive blood. So this is group, right? But it is quite possible that my blood group is O positive and I have got a blood from a blood bank, O positive blood bank. This blood is grouped matched, but it is not crossed matched. What does that mean? It is quite possible that in this blood, the bag which has come, there may be antibodies against the antigens present in my body. So to check for that, what I'll do, they do in blood bank, they take the blood from a recipient and they take a blood from the bag and they mix them in a slide or in a test tube, right? And they mix it and see to it whether any agglutination reaction is happening or clot formation is happening or not. Because if there is a antibody present in that blood, which are against my antigen, the blood is matched, but there can still be antibodies present in that blood bag. So this is called cross matching. So this clot formation which we are seeing takes at least 45 minutes. So you can appreciate, please understand this concept. You can appreciate immediately after ringer lactate of 1 liter, you are in need of blood. And this cross matching, which is a preferred thing always, is going to take at least. So it is quite possible by the time you need blood, you don't have a cross-matched blood with you. You don't have a cross-matched blood because cross-matching takes, but preferred is always a cross-matched blood. So we don't have a cross-matched blood most of the time. But preferred is always a cross-matched blood, but we don't have it most of the time. So what we do? So if a question asks, what is the most commonly given blood in a trauma resuscitation? It is O negative. We give O negative blood, right? If cross match is not there, then only we give O negative. And most of the time, since it is not there, our answer for trauma resuscitation for blood, if asked, will be O negative. But if the language of the question is such, which of the following will prefer in trauma resuscitation? We always prefer cross match. Because जैसे the moment cross match blood get ready, I will not be giving O negative, I will be giving a cross match blood. Understood? Right? Now, till the time cross match blood is getting ready, we will give O negative blood. So most commonly given blood is O negative, but preferred blood is cross match blood. Now, the adequacy of fluid resuscitation, very commonly asked question. Adequacy of fluid resuscitation is best assessed by adequacy of fluid resuscitation is best assessed by urine output. Adequacy of fluid resuscitation is best assessed by urine output, and the goal of urine output in any resuscitation is more than 0.5 ml per kg per hour in an adult, more than 1 ml per kg per hour in pediatric. The goal of urine output which you have to achieve in any resuscitation is more than 0.5 ml per kg per hour in an adult, more than 1 ml per kg per hour in pediatric. And please be very, very careful about the language again. If they ask you requirement of the fluid, is best assessed by requirement of the fluid. If they ask you is best assessed by, your answer should be pulmonary, capillary, wedge pressure. If not in your choice, then it is central venous pressure. Pulmonary, capillary, wedge pressure. If not in your choice, then it is central venous pressure. Then it is